Now, because I'm in sports and exercise medicine, I'm a sports and exercise medicine physician, any WhatsApp forward which comes related to exercise, the whole family is sending it to me, right? So this especially, because this says that I exercised once, but I found out I was allergic to it. My skin flushed, my heart raced, I got sweaty and short of breath. Very dangerous, right? So 5 people have sent this to me. Tvisha, you asked us to exercise, but this is what exercise does. Yes, very true, exercise is a stressor. One of the reasons that we require a guideline for exercise. But exercise tends to be the first line management for a lot of the conditions, from diabetes, obesity. Most of our textbooks, from Harrison's to whatever, did mention exercise as the first line of management. But here's what happens. The patient comes back saying, doctor, I've been exercising every day. Neither has there been a weight reduction, nor have my sugars come under control. So that's why we require a guideline. Imagine somebody took a 50 milligram paracetamol. Is it going to be of any effect? No, not really. And imagine they are overdosing it, right? So that's where exercise is. Exercise is a medicine. The two major things that define it is the type and the dosage. That's how you would prescribe it. So just the way if somebody needs an anti-diabetic drug, you don't really end up giving them an antibiotic, right? That's not going to serve the purpose. So that way exactly, if the type of exercise determines whether it's cardio, weight training, the two major groups. Within that, there could be all the other things that Dr. Contractor just mentioned, but essentially these are the two major groups that we talk of when we're talking of exercising as a prescription. Coming to the dosage, would it help if a medicine which had to be taken TDS was taken only once a week? And what if the vitamin D prescription of 60,000 international units ends up being taken every day, right? All of that is going to be a problem. So that's where, again with exercise, we need a prescription. Does it have to be done daily, alternate days, 30 minutes, 1 hour? You know, Dr. Contractor again mentioned about the duration, etc. a little bit. So that's what we talk of in exercise prescription. And that is the requirement of an exercise prescription. Typically, it's defined, it's described as the FIT principle. This is the common way of describing it. That is frequency, intensity, type, and time. The same things that I mentioned in the previous slide, so we're talking type and dosage. And that's what an exercise physician's prescription would look like, yeah? So the one over there where we are describing the prescription, fit prescription, weekly, daily, what is the exercise dosage, what is the type of exercise that somebody is going to take. Now, before we prescribe any medicine for anything, whether it's diabetes, it's an antibiotic, we are going to ask for a blood culture, we're going to ask for some tests. So because just the way we ask for blood tests, before we start an exercise prescription, we do request preferably that there is an exercise test. One of the simplest ones again mentioned by the previous speaker was the walking test, like a mile walk test, okay. So there's a whole range of tests which can be done. This book, if for those who are interested a lot in exercise prescription, this is kind of the Bibles when it comes to exercise testing and prescription. The ACSM guidelines, which are kind of followed pretty much throughout the world. So what is the possible pre-exercise testing that could be done? Depending on various factors, which I will discuss, it could be just simple verbal consultation, like, you know, just a consult like I did for the previous patient. I didn't ask for any tests or anything, a verbal consultation and gave off a prescription. It could be a basic medical examination. It could be a little more severe like a resting ECG echo, a little bit more like a stress ECG echo, and the list can go on. It could also be doing an angiography before we prescribe an exercise program if required. So the exercise testing, the basket is, it's left to the physician who is seeing how much to do, right? When I say the more, at times what I also end up doing is a little bit of psychological assessment of the patient, okay? Like it was mentioned by somebody in the morning, that we need to assess what the patient is going to be able to do. So that's when, you know, a little bit of psychological assessment. So that would be the entire gamut of the pre-exercise testing. So when I mentioned about what decides these factors, 4 major things. Is the person currently having any diseases? Are there any sign symptoms? If he's not having any diseases, but are there any sign symptoms? Is he or she showing any manifestations, complaining of anything? What is his current physical activity status? For the same person who is having manifestations or complaints or a disease, if he is already doing 42K on a, twice a year, yearly basis, his plan might be a little different than somebody who is starting afresh, right? What is the desired PA again? PA is physical activity. So what is the desired PA? Is my goal that, I should just be able to do that 1 hour or half an hour of morning walk? Or is my goal the next Mumbai marathon? What is the patient's goal? And finally, what are the medicines the patient is already currently on? Because commonly attributed medicine is like a beta blocker. So if the patient is on a beta blocker, there's going to be bradycardia. We might want to do a little bit more of exercise testing, detailed exercise testing to see if it's going to have, what effects is it going to have. So before I move on to the prescription per se, certain definitions of exercise, some people in the audience might be aware, but for those few who may not be, what do we mean by a regular exerciser? Again, these definitions are by the ACSM, the American College of Sports Medicine. Somebody who is performing planned, structured physical activity of at least moderate intensity for at least 30 minutes on 3 or more days of the week during the past 3 months. Okay, that's what makes somebody a regular exerciser. If he exercised back when he was in school and he was a sprinter in school and today he is 40 years old, he cannot be calling himself a regular exerciser, right? Then there's a term in there which says moderate intensity. Okay, so what do we mean by moderate intensity? Again, some people might be familiar with the METS concept. Typically when we ask for a stress test, we see this METS reported as part of a cardiac stress test. So typically moderate intensity exercise is something between 3 to 5.9 METS. For a further, more detailed and a relative, that's a more absolute thing. For a more relative thing, patient specific thing, the intensity is described as, in aerobic, it's 40 to 60% of the heart rate reserve or VO2R. Okay, HRR is something called heart rate reserve, and resistance exercise is 50 to 70% of 1 RM. 1 RM is a repetition max. Okay, I'll just describe the, so that's moderate intensity and that's vigorous intensity exercise. So what do we mean by the METS? So METS is a concept wherein light METS is less than 3 METS, okay. So these are the activities which come in less than 3 METS, okay. The activities which come in moderate METS and those which come in vigorous. But if you might see, if less than 3 METS, which is a very light or light activity, is something like standing, performing light work such as making a bed, washing dishes. Now imagine my 80-year-old granny, okay. If I ask her to do it, is she going to be very comfortable? If she's fit, yes, but if she's not, she's going to be probably huffing and puffing. So that's where the concept of the HRR and the relative exercise intensity concept comes in, and that's where to assess these things can be estimated using certain formulae, but it would be, if you require this, it's very ideal that we get a exercise stress test done, because that's when we will know what is the person's heart rate max. If we additionally do functional testing, like one of the pictures that Dr. Contractor showed, wherein there's a mask and the person's doing a test, that actually gives you the maximum oxygen consumption, a little bit more precise method to do an exercise prescription. Nonetheless, if you don't have the resources for this very often, which most of the places may not have, the simplest way could be the Borg scale. Okay, again, it was described, there are 2 types of Borg scale. This is the newer one. The one which Dr. Contractor showed goes up to 20, starts at 11, no, starts at 6. So that is on the basis of that scale. Was any ideas from anyone? Why did they decide on the numbers of 6 to 20? Anyone? Do these numbers 6 and 20, or maybe 60 and 20, can you think of something when we're talking of exercise, heart, 6, 20, 60, 20? That's the heart rate, yeah. So if somebody is at 6 RPE, okay, or 60, when their heart rate is 60, they are basically pretty relaxed. And if their heart rate is at 200, then they are really puffed out, they are exercising. That's how that scale was devised. But then we decided, then when we were using this for exercise prescription, then scientists realized that it's a very cumbersome scale. You know, I tell someone ki between 66 and 20, tell me how severe are you exercising, or can you exercise at 11? So that's how it was redone, and they made a simple scale like how we have the pain scales, the VAS scales, a simple scale going from 0 to 10. 0 being I'm completely relaxed sitting on a beach and chilling on a beach, 10 being I'm fairly puffed out, yeah, while I'm exercising. So that's one of the easiest scales, one of the easy scales to use to define exercise. There are certain other scales like the talk test, which says that, you know, if you're walking comfortably, there will be this many words that you can speak, this many sentences you can speak comfortably. But this one tends to be, at least the one I use most commonly for my patients. So that was about exercise intensity and exercise testing. Now moving on to the prescription part. So before we do the prescription, again, like as part of the testing, if the person is, my talk is on exercise prescription guidelines. So if we talk of general healthy population, they could do something like this. It's called the PAR-Q, or the Physical Activity Readiness Questionnaire, which is available. So it's again part of the SESM book and their guidelines. So if the person basically answers no to everything in this questionnaire, which is like a 3-4 page document, then the person can go ahead, start slowly, build up gradually from 20 to 60 minutes of low to moderate intensity exercise 3 to 5 days a week, which should include aerobic as well as muscle strengthening exercises preferably. However, there's this brilliant line at the end of this questionnaire which says, if in doubt after completing the questionnaire, consult your doctor prior to physical activity. So that's where probably all the doctors in the audience would come into play, that your patient's going to come to you saying that I went to the gym, they asked me to fill up this questionnaire, and I've marked out, you know, I had some doubts, I've been positive on certain questions, so they've asked me to come and get your clearance, okay. So once there is a clearance, then then like I mentioned, you go through the exercise testing and decide what to do. Now because we are dealing mainly with diabetes and obesity, I've focused on those two things, part of which is lucky because good contractor didn't speak on obesity exercise prescription. So as part of diabetic exercise testing, would you require testing? Yes, exercise testing in the form of cardiorespiratory as well as muscular fitness. Just doing the walk test may not be sufficient, because if in the gym the person gets the trainer or whoever gets the person to do say 10 push-ups, is the person ready to do 10 push-ups on day one? Okay, so that's the reason we need to know what's the person's baseline value, what is it that he can manage. That's when the testing comes into picture. So for light to moderate intensity, there's generally not a necessity of doing testing in people with diabetes or pre-diabetes if they are asymptomatic or their cardiovascular disease risk factor is low. But if they are positive for any of that, you see a physician, you get one or many of the tests done. If it's high intensity exercise, you would usually definitely ask for at least an ECG stress test, which is basically a routine cardiac stress test. That's the bare minimum we would ask for. So in spite of saying all these, talking about all this testing, the detection of ischemia in asymptomatic diabetes trial, which involved more than 1,000 people with diabetes and no coronary artery disease, found that screening for myocardial ischemia over a roughly 4 to 5 year period follow-up did not alter the rate of cardiac events, okay. So we obviously need to balance out, especially in a country like ours where insurance is not there for outpatient basis, whether do we want to put the patient through a lot of tests or do we want to, you know, get away with a safe exercise prescription. So this is an exercise prescription again taken directly from the ACSM. Talks about aerobic resistance flexibility exercises, and like I mentioned, it describes the exercise in the FIT principle. Frequency, so aerobic activity to be done 3 to 7 days a week. Intensity, moderate to vigorous physical activity. Time and type, fine. So this it does for aerobic resistance and flexibility exercises. Although we talk of all this, sometimes for the diabetic patient, it might be just enough to get up and move. Again, like Dr. Contractor mentioned, you know, just a little bit of movement might be enough if we do not want to get into all the fancy stuff. A little bit of caution with the diabetic patients looking at comorbidities. Resistance exercises may not be safe for everyone, especially if they've had certain surgeries, if they have hypertension, retinal complaints. Hypoglycemia is something you want to be very, very cautious about, because when a person starts off a new program, there's a high chance of it. Autonomic neuropathy and also to be something to be cautious about, and remember, nephropathy is not a contraindication. Next, coming to the obesity exercise prescription, fairly, I'll take a couple of minutes, just maybe a minute. Obesity exercise prescription, again, whether testing is required is highly governed by the comorbidities. Person's diabetic, has cardiovascular disease, has dyslipidemia, all of that matters. As far as the prescription is concerned, with obesity you need to exercise a little bit more, because like we've spoken through the morning, it's about energy expenditure, it's about input and output. You definitely need to increase your output. So it is more than 4 days a week. The rest of the stuff kind of similar when it comes to diabetic patients and obesity patients, but this is something which matters. Something very important for the for the obese patients is physical activity is necessary to prevent weight gain. Again, like was mentioned in the previous talk, how much effect does food make and how much effect is made by physical activity may not show direct influence a lot in the beginning, but when we are talking prevention of weight gain, it definitely has a big role. Exercise considerations when obese patients, I think the biggest one for me is that they need to really exercise 250 to 420 minutes a week. That's what they want to achieve if they really want to see significant weight loss, okay. So, certain practical situations, this is about theoretical exercise prescription, but practically the person could have a discomfort with exercise, a particular exercise. That's like somebody, you prescribe a medicine or you prescribe some food and the person's allergic to it. So that back and forth has to happen between the physician and the patient. The patient could have an injury with exercise, okay, in spite of it being a very prescribed program. Usually, like that's similar to a diabetic getting a hypoglycemic attack. So it's not that the prescription was wrong, but the patient probably did something too much or too less, and that's how it mattered. Exercise not having any desired effect, can that happen? Yes, that can happen, just the way a diabetic doesn't come under control because he's taken one arm of the treatment, he's taken the medicines, but he's not following the dietary prescription. Lastly, the person, if he doesn't exercise, it's obviously not going to have an effect. So what I would like to conclude with, just the way we have P-drug, we studied about P-drug in pharmacology, every doctor has a P-drug so that they know everything about it. In exercise, the P-drug is what is the patient comfortable with, okay? With exercise, there's a lot of motivation and active involvement from the patient. So the physician's P-drug, I am an expert in yoga, so yoga will work for my patient, no. Is he compliant to it? Prescribe what is followable by the patient, provided it is safe and effective. Lastly, a word of caution in view of all the medical legal stuff. If doctors are prescribing exercise, do make a prescription of the do's and don'ts to keep you on the safe side. What are the things that have to be avoided? Is that okay? Thank you.